Is that a correct understanding of the policy of this committee, Mr. Chairman?
So Senator Scott, that's what we talked about on the first day. And so it takes 3 aye votes out of this committee to advance a bill to the floor. I'll leave it up to the committee if they want to table it for further consideration on Wednesday, which is our last day. And we have 2 bills for Wednesday. So I caution you, if you can't dispose of it
My
today,
policy will be to leave that open for you to deal with.
my policies, get the bill in or out. Senator Scott.
Okay. Okay, with that, first bill for consideration is House Bill 164, medical prescriptions, off-label purposes. Okay, sponsors are here. Proceed. Identify yourselves and proceed.
Thank you, Mr. Chairman. My name's Gary Brown, representative for House District 41. I will be presenting House Bill 164, medical prescriptions off-label. To my left is former Representative Sarah Penn. She brought this bill in the past, and she's come to get into some of the more technical things with me. So I will attempt to walk us through this bill. This is an act relating to professional and occupational authority prescribers to prescribe medical prescription off-label indications as specified, authorized physicians to dispense medications for off-label indications as specified, providing prescribers and pharmacists immunity from disciplinary action as specified, providing for stable severability of provisions as specified, providing definitions, requiring rulemaking, and providing for an effective date. We'll go through definitions under subsection A, Romanet I. This disciplinary actions, and this just goes through and explains the disciplinary actions that could take place and how we would deal with those under the licensing board. And then under Romanet 2, off-label indications, and it gives the definition of off-label indications. Romanet 3 is pharmacists. It's just the definition by state rule, state law as to what a pharmacist is. Under Romanet 4, prescribers, and that going through that is physicians, physicians assistants, dentists, optometrists, advanced practical registered nurses. And then prescribing drug off-label indication exceptions. And I'd like to go through this a little bit more. Notwithstanding any other law, a prescriber may lawfully prescribe a United States Food and Drug Administration approved prescription drug off-label indications for off-label indications, and a pharmacist is authorized to dispense a prescribed drug for off-label indications within their scope of practice pursuant to a valid prescription order. And just to define that a little bit, for instance, a optometrist could not prescribe off-label for an impacted tooth. That would be something that a dentist would do. So just to go through that. Under subsection B, exceptions, Romanet I. So this is a list of Schedule 1 and Schedule 2 controlled substances under the federal law or the Wyoming Controlled Substance Act of 1971. And those I have here just an example. For instance, under Schedule 1, marijuana, LSD, ecstasy, and heroin would be under Schedule 1. Schedule 2, cocaine, opium, high-grade morphine, OxyContin, and methamphetamines. So those would be exempt from being used off-label, of course. And then under Romanet 2, intended for transition of a minor. So what we're dealing with here is in 2024, this state outlawed the transitioning of minors in the state of Wyoming. So this would not allow people to transition minors. And then under Romanet 3, intended to induce an abortion. And 2023 Senate File 109 was passed through this body and the House, and then the governor signed that, and that has to do with chemical abortions. I know that that's tied up in the courts right now, but we just want this in here so that people will not misunderstand. And then under subsection A, professional conduct, that lays out what would be considered professional conduct and what would not be. And it just points out that a physician could not be penalized for solely based on the fact that he prescribed medical medications off-label. And then on page 5, we have a severability. This was put in the House committee, and this is just put in so that if, for instance, the court finds against us in on the abortion issue, that this would make it to where the whole bill is not found to be outside the law. And then on to subsection, or to section 2, it just explains that that if this is passed, that the Board of Medicine would make sure that all the rules and stuff are put into place and necessary to make this act work. And then under section 3 is the effective date of July 1st. And now I will turn this over to Sarah.
Ben, go ahead.
Thank you, Mr. Chairman. So as he said, my name is Sarah Penn, and I was the original bringer of this bill a couple of years ago. I know that a couple of the members of this current committee have had this before them once before. So I wanted to make sure that we understand exactly what we're talking about. First of all, it's important to understand that 20 to 30% of all medications that are currently prescribed are prescribed off-label now. That is being done. It's oftentimes what we might say standard of practice to kind of repurpose medications. We understand how they work, we understand how they interact with the body and what their mechanisms of action are, and we find that because it went through FDA approval under this use, we may still also be able to use it for this other thing. So it has been through the FDA approval process, just maybe not for that specific use. I also want to point out that and ensure that you understand that the FDA focuses on the market entry of drugs, and that they consistently maintain that they do not regulate the practice of medicine between physicians and patients. The FDA clearance ensures that physicians understand how a drug effectively produces a physiologic action and how it is proven to treat an illness, but it's the physician, not the FDA, that determines whether these specific effects would be useful or beneficial to the disease process affecting a patient that's sitting in front of them. So what is the need? You know, we had the pandemic a little while ago, and I think that what that revealed to us was kind of a chink in the armor of how things work. We need to protect and preserve the integrity of the practice of medicine and allow providers to retain the autonomy to use their clinical judgment and benefit each individual patient that sits in front of them. And patients need providers to be able to have that latitude to make the choices that are best for that individual. So a couple of examples quickly on medications that have been repurposed, off-label. They're the medication metformin, used often, every day, probably thousands of prescriptions for metformin get written. It's on label for treatment of diabetes, lowering blood sugar. But it's also now being repurposed or used off-label for treatment of cancer. We're seeing this happen over and over again. The medication propranolol is a beta blocker. It works on the heart, it works on blood pressure. That's the original purpose for that. But we found that, guess what? It helps with headaches. It helps with performance anxiety. It helps with one of the newest findings that I just uncovered is post-surgical prevention of post-surgical metastasis. And so doctors need the ability to apply these medications where it is appropriate in the care of their patients. Also, the reason that we need this codified in our statute is to ensure that, again, these physicians can treat their patients the way that they want, and pharmacists are not afraid to fill those prescriptions. I am a nurse practitioner. I worked through COVID, and I treated a lot of patients during COVID, I had pharmacies tell me, I can't dispense that even if you prescribe it because I'm afraid I'm gonna lose my license if I do that. You will probably hear testimony that no licenses were revoked in Wyoming for this, and that's right, no licenses were revoked. But I promise you that it was testified previously that investigations were done, threats were made within our state, and that absolutely affected the ability for patients to access the life-saving medications that they needed and deserved. In fact, I emailed you last night with some testimony from previous committee people who had very compelling circumstances and situations. They weren't able to be available today to testify again, and so I would ask you to review some of those previous testimonies because the stories are compelling. People who were begging for these medications, offering to sign waivers so that releasing the hospital of any liability, because we want these medications, they were told no, and their family members died. I guess at this point I would ask for any questions, stand for questions.
Okay. Committee, any questions for the sponsors? Seeing none, I'm going to ask a couple. First is just a technical question. On page 5, the severability, there's a general severability clause in Title 8 that's generally regarded as covering all the severability needs. Why do we need a separate one here?
Thank you, Mr. Chairman. This specifically, this was put in by the committee chairman in the House committee, and he felt that it was important to put in because we have a pending legal case here in Wyoming dealing with chemical abortions. So the reason that this was put in was that if the court finds that case in chemical abortions, that will continue, that they make that to where that is a constitutional right for them to continue to use chemicals for abortion, that would not just throw this bill completely out because it has it in there. By severing that, just a thing to make sure that doesn't happen.
I'm seeing this in a number of bills, and I think we're getting away from the value of the Title VIII general coverage, which I think is perfectly adequate. So we'll have a question on that. On page 3, subsection A, that looks to me to be the heart of this bill. Why is that not just a restatement of the current law verbatim?
Mr. Chairman, to confirm, you're talking about, did you say subsection, or section A?
Lines 13 through 18, it reads to me like what the law has always been, because as you testified, their use of prescriptions off-label is very common. You do have the food and drug approval, which means that the safety of the things has been looked at. But they haven't, their procedures are so cumbersome, they don't find all the potential uses, and they don't cover all the potential uses. And off-label prescribing is very, very common, as you testified. So what's different here?
Yeah, thank you. So I believe that what I feel is the meat of this section is line 17 and 18, where it says that ensures that we are making, that they're prescribing within the scope of their practice and have a valid prescription order. I have had individuals reach out who, glanced over the bill and said, wait a second, but does this allow a optometrist to start prescribing birth control? Or does this allow, as Representative said, is a dentist, are we working within our proper scope? And when I point people to this particular section, then the general result is, oh, okay, I feel better now. So I think that's what the point of this section being included in the bill would be.
Okay. Anything else? Committee?
Mr. Chairman.
Senator Barlow.
Thank you, Mr. Chairman. So, and I appreciate that. It seems like on line 17, it should be instead of their scope of practice, it should be the prescriber's scope of practice, to be more specific. Would that be something that you would agree with? Thank you, Mr. Chairman.
That, if you look at line 16, I'm sorry, Mr. Chairman, if you look at line 16, it's actually talking about the pharmacist in that line. So it says a pharmacist is authorized to dispense a prescribed drug off-label indication within their scope of practice. So they're referring both to the pharmacist and the prescriber with that sentence. And so I think if we change there to prescriber, I think we cut out the pharmacist in that sentence.
Okay, thank you, Mr. Chairman. Mr. Chairman, can I call for the second question?
Go ahead.
Second question is on actually page 4, and this will be a question that all the licensing boards that come up can respond to as well. Line 18 talks about, I understand licensing board disciplinary action, i.e. anything that has to do with their license, but I'd like some relation to loss of employment, hospital privileges, and credentials, because I don't see that as being related to any action that a licensing board would take. So any comments on that? Thank you, Mr. Chairman.
Okay.
Thank you, Mr. Chairman. Senator Barlow, I think that the point is just to drive home that there would be no overreach with the board in affecting privileges or credentials.
Okay. Do you see any licensing boards that can take away, they take away licenses, they don't take away hospital privileges? That's not their business. It's an effect of what they do if they lift the license, but.
Mr. Chairman, thank you. What might have happened in here, this is actually there was an edit in the House. How the line used to read was loss of employment. Is that the spot? Okay, on line 17, it used to read relating licensing board, comma, or employer, including disciplinary action. And so I think that once we removed employer in a previous amendment, then that does cause a little bit of ambiguity with line 18.
Okay, I can understand. We can clean up the housework. Okay, anything else? Anything else? Anybody else here present want to testify on this bill? Anybody else? Yes, ma'am, in the back, and then Mr. Bonenblast, your second. So come on up, and we're going to try to rush this a bit because we got a horde online that want to testify. Okay.
Mr. Chairman, I'm Linda Bird, and I'm representing Wyoming Right to Choose. Just briefly, since this has already been mentioned, this law is really an unnecessary law at this point, as former Representative Penn did testify, 20 to 30% of prescriptions are already given off-label, and there is nothing in the current law that would not allow a physician or pharmacist to prescribe an appropriate and safe medication. This is just not necessary at this time in terms of addressing any kind of problem. Implementing the provisions of this bill could be very challenging, since the bill's protections exclude Schedule I and Schedule II controlled substances. Someone would need to monitor prescriptions to assess whether the purpose is for off-label uses. 236 drugs are listed on Schedule I. 70 drugs are listed on Schedule II. Implementing the anti-abortion provision of this bill could also be problematic. For example, the drug misoprostol is one of the drugs that is used in medication abortions. It is also used to treat other things such as ulcers. Someone would need to determine what the prescriber's intent was, which could involve looking at patients' medical records. The other thing I would like to say about that is that abortions at this point in time are legal in the state of Wyoming. So having this in the bill is problematic, clearly. Pharmacists could also be reluctant to fill prescriptions because they might be in fear of running afoul of these exceptions. So I think this bill is unnecessary, and I also think it's extremely complicated in terms of enforcing this kind of bill. Any questions?
Question? Seeing none.
Thank you.
Mr. Bonneblast, and then.
Thank you, Mr. Chairman. Senators, Kevin Bonneblast, Executive Director of the Board of Medicine, licenses and regulates practice of medicine by physicians, that's MDs, DOs, and then PAs as well. And as was mentioned, let me make this clear on the front end, the Board of Medicine has nothing to do with anybody's employment or hospital privileges or credentials. That's not even in our ballpark. So that's, even if we wanted to, we couldn't affect those. I would note that, as Representative Penn stated, that we have taken no license actions, whether it was in COVID or anything else related to, because of off-label prescribing. As she mentioned, somewhere north of 20% of all scripts are actually written off-label, and it's common. And so if this were really a problem, we'd already be doing prosecutions. And as far as I know, at least in my 18 years and beyond that, I don't think anyone has ever had a medical license affected by off-label prescribing in and of itself. Now, if they fail to meet the standard of care, if they don't get informed consent, things like that, that's going to be a whole different situation. But just for off-label prescribing, this is basically, it's a solution looking for the problem. We haven't had that problem. I know other states have, and I know that there's various stories out there, but I can just tell you that our board has never, to my knowledge, ever brought a case simply because somebody was prescribing off-label. So with that, I would stand for questions and just to give you the licensing board perspective.
Senator Steinmetz.
Thank you, Mr. Chairman, and thank you for being here to answer some questions. I had pharmacists telling me that they were not allowed to dispense hydroxychloroquine and ivermectin during COVID.
Okay, Mr. Chairman, Senator Steinmetz, first off, they may have been telling you that, and yet I don't believe the Board of Pharmacy took any actions either. I can't speak for them, but I do not believe they did. Now, something to bear in mind is that a lot of the corporate pharmacies prohibited their people from doing that, to my understanding. And so that's a whole different master that's being served there. It's not the license. And I can't really speak to pharmacy just because out of deference to that board. But another thing we do find sometimes with physicians is that they will tell a patient, I can't do that because the board's going to do such and so to me. And we've never said or done anything like that. Now, what the board did do with hydroxychloroquine was to say, meet the standard of care. And there were very specific emergency use authorization guidelines out there. to help make sure it was safely given. Meet the standard of care is what the board said. Always has, always will. So as far as what a pharmacist, thought about it, I don't think they took any licenses with pharmacy, but then again, it's not my house.
Thank you.
Senator Hutchins?
Thank you, Mr. Chairman. Mr. Bonaplost, is that correct?
Very close. Thank you.
Close. So my understanding of the bill is they're just trying to codify the actions that are already being done, which to me, I don't have a problem with. And in the section that we're talking about, in question on page 4, professional conduct, if we take it back to the original language, does that help you out at all?
Mr. Chairman, Senator Hutchings, I guess I'm not sure which original language you're talking about doing, putting it back in so you can't have an employment action and things like that?
Yeah,
or-
it looks like the House removed the prelude to this language, and the language is including disciplinary action, loss of employment, hospital privileges or credentials. If we took that out, that would affect what the House, that would implement what the House did by removing the licensing board or employer.
Mr. Chairman, if I might, I think that if that's what you're trying to accomplish, strike entire line 18.
Yeah,
And then
18
it
of
works.
the previous three words on,
Yeah, just strike line 18 and that gets you what you want.
Thank you, Mr. Chairman.
okay? So, Linda, did that cover?
Yes, sir.
Let me ask you, assuming we do that and clean that part up, would passage of this bill in any way alter what the Board of Medicine does now?
Mr. Chairman, I can't see that it will. It's basically a practice that's already in place. It's never been prosecuted. You can go ahead and pass the bill, but I don't think it's going to change anything.
Okay. And I would specifically point you to the language on page 4, starting on line 19, solely on the basis that a prescriber prescribed, et cetera. So if a prescriber prescribed something that had been approved for something else that was known to be harmful in a particular circumstance and did that sort of thing persistently, then you could take action against them. It's not solely because they're off-label, it's because it was off-label and well outside the standard of care and known to be dangerous.
Mr. Chairman, that's correct. And so it would be looking at things like, did you have informed consent? Did you let the patient know that they were at risk of this kind of injury? Did you meet the standard of care? Were you providing appropriate care at that level? Because there's nothing in the Medical Practice Act that prohibits off-label prescribing, not a word.
Okay. Anything else? Thank you very much. Yes, ma'am.
Thank you, Mr. Chairman, members of the committee. I apologize, I was hidden behind that little post there, so you couldn't see me. My name is Patricia McCoy. I've been a resident in Laramie County since 2007, and I'm here to speak today in strong support of House Bill 164. This bill could make a profound difference in my life, as well as the life of many others in Wyoming who face complex health challenges. I personally am someone who has been struggling with a combination of chronic conditions that significantly impact my daily life. Conditions like persistent pain, debilitating migraines, anxiety, and chronic fatigue. These issues are far from straightforward or easy to treat. They often overlap, creating a challenging puzzle that standard medical approaches have struggled to solve. Over the years, I've tried numerous medications, I've seen specialists, I've had injections in my head, like you name it, I've jumped through all the hoops. And I've followed the recommended treatment plans, but the relief in everything that I've tried is either temporary or incomplete. I said, and these challenges of going through all of this and jumping all these hoops, it affects not just my physical health with the headaches and the chronic pain and stuff, but it also affects my mental well-being and my ability to work and my overall quality of life. When you can only fold one load of laundry and then you're done for the day, it's kind of hard to have a nice day after that. Off-label prescribing using a medication for a purpose not originally approved by the FDA can sometimes offer hope for patients like me, especially when conventional treatments fall short. However, this practice is far from easy or common. It's actually quite difficult and heavily discouraged due to the significant legal and professional risks it poses for doctors and pharmacists. The fear of potential lawsuits, licensing board actions, or professional repercussions often prevents healthcare providers from even considering off-label options, even when research or clinical evidence suggests that they may help. This creates a barrier that leaves patients like me in a constant cycle of trying to take different medications and treatments and getting nowhere. House Bill 164 offers a critical solution by removing these barriers and protecting prescribers and pharmacists from disciplinary action or loss of licensure solely for prescribing or dispensing medications off-label, as long as it's done within their scope of practice and with a valid prescription. For someone like me with overlapping and hard-to-treat conditions, this protection could be transformative for my life. It would allow my healthcare team to explore innovative approaches that we have discussed, and potentially combining or repurposing existing medications in ways that address the unique interplay of my symptoms without the constant threat of professional risks. For example, a medication approved for one condition might help alleviate my chronic pain or anxiety, but without this bill, my doctors are hesitant to try things that we've discussed due to the other risks involved. This bill would give my providers the support to think creatively and adapt treatments based on the latest scientific understanding rather than being constrained by fear of repercussions. It's not about untested or unproven therapies. It's about using safe, FDA-approved drugs in ways that evidence could potentially support, but the necessary evidence cannot be accumulated because current regulations prevent their use for these purposes until they've been formally researched, a process that is complicated and difficult to navigate. As a Wyoming resident, I'm asking for your support to pass this bill into law. It's not just about policy, it's about giving me and others like me hope, reducing our suffering, and improving our lives. It would ensure that I have access to the most personalized and effective care possible, and I urge you to please support this bill. Thank you.
Questions? Seeing none, thank you very much. Anybody else? Anybody else? Yes, sir.
Yes, good afternoon, Mr. Chairman and Senators. I'm Dr. Willard M. Woods. I've been practicing for 53 years, 10 years in the Army before I came to Wyoming, and have been in rural practice there for 40 plus years. In all that time, I never considered even the possibility of being dictated how to practice medicine by non-medical corporate entities. But this did happen. During the COVID pandemic, the only answer to why these life-saving, generic, safe, inexpensive drugs were denied for use by me and other practitioners was money. The use of off-label repurposed drugs you've been hearing today is a staple of good medicine, especially when it's life-saving. But early treatment of COVID was keeping people out of the hospital, thereby denying corporations their monetary windfall. COVID is mostly over now, but the loss of life and well-being for millions of people will never be forgotten. And I appreciated the posture of the Wyoming Board of Medicine. They used common sense to not penalize doctors during that time, thereby protecting the public as well. So this brings us to HB 164. What about the next pandemic or virus or disease that there has no approved treatment? Will providers be prohibited from using their training and experience of using off-label meds shown to be effective for fear of retaliation because it may affect the corporate bottom line? Yes, pharmacists were told by their corporations, do not prescribe this medicine. One lady actually said, one pharmacist, it kills people, talking about hydroxychloroquine. Well, that's ridiculous, but that's what she was told. My termination for using off-label medications to treat COVID patients successfully sent a message to my colleagues that they would suffer the same consequences. This bill would allow providers to be the clinicians they were trained to be. I ask you to please support this bill. Be happy to answer any
Any
questions.
questions? Seeing none, thank you very much. Go ahead.
Good afternoon, Mr. Chairman, committee members. Eric Boley with the Wyoming Hospital Association. And a lot's been said about this bill. We believe that this bill is unnecessary. And I think if we're going to be honest, let's call this bill what it is. We're relitigating COVID again. And we're talking about ivermectin and hydroxychloroquine. As has been stated, off-label prescriptions have been used for years. One of my very best friends, he was a hospital administrator for 30 years in our state, had terrible cancer. He was prescribed medication for breast cancer that kept him in remission for many, many years. He ended up paying $25,000 a month out of pocket because it wasn't covered by his insurance company. But he used that and it extended his life for several years. As we talk about hospitals and doctors and privileges, there are safety guards in place, and this isn't about corporate greed. This is about patient safety. As a former hospital administrator with 20 years experience, we used to meet monthly with our medical staff, with our pharmacy, and we had what was called our P&T meeting, Pharmacy and Therapeutics, where we would discuss what we would keep both in our formulary and our pharmacies, as well as what would be allowed to be used in our hospitals. And that went through the entire medical staff. Medical staff also has their own rules and regulations. That's what is used to dictate what happens in our hospitals. It's not our corporations that decide. It's not our elected boards. It's our medical staff. One of the things that I'm really concerned about with this bill is that there is no repercussion if we find something is amiss. And I'll use an example here. Let's say that you have patients that were admitted to your hospital by a provider, and another provider takes it upon themselves to sneak ivermectin into those inpatient stays and gives them ivermectin against what has been decided by medical staff, by P&T committees. What is our recourse? And what doors are we opening if we continue to do things like that? As employers, we have to look out for what's best for our patients and for our employees. And that's why we have committees. That's why we have medical staff. That's why we discuss these things. Early on in the pandemic, there was a lot that went on with ivermectin and hydroxychloroquine, but then remdesivir came out and hit the market. And we actually helped push remdesivir all over the state to help treat COVID patients. So I would just say that if we're going to pass this, we need to put some protections in to allow employers to be employers. But I would also say this is really unnecessary, is we're already allowing off-label prescriptions to be used. With that, I'd answer any questions.
Questions? Senator Hutchins?
Thank you, Mr. Chairman. Mr. Boley, Dr. Woods is not the first doctor I've heard of that's been let go during the COVID situation. Do you know of any others outside of maybe 1, 2, 3, 4, 5, 6, 7, 8, 9, 10?
Chairman Scott, Senator Hutchins, I'm not sure of exact numbers, but I would also tell you that when it comes to employment issues, there's a lot that can't be talked about in public meetings, and there's a lot that I don't know about because that's between the employer and the employee.
Follow up? You mentioned those specific drugs, and I'm wondering about informed consent. If a doctor informs this patient, this is a drug that's used for this, and I'm gonna try this, is there issue with that for you? Because this bill will allow that.
Mr. Chairman, Senator Hutchins, it's already allowed.
Okay, one more. You said there are bad doctors out there that may come in and secretly give someone a drug that is off label. Couldn't that happen? If it happens now, and it happens with this law, what's the difference?
Mr. Chairman, Senator Hutchins, I'm not sure I said bad doctors, I said
Well,
doctors.
sorry.
And if the bill is passed in its current form, we have no recourse. If the bill is not passed, this basically protects the doctor from doing almost anything they want and keeps them safe from doing that. If there are policies and procedures in place within a hospital or a clinic setting, this precludes any action. We've talked about removing their licenses, but unless we fix that line 18, which I think is very important, that is a protection that would allow us to continue to operate as an employer and have an employer-employee relation. But without that, it basically holds them harmless on anything that they do.
Can he explain that to me? Anything that they do, or is this
Well,
just
if
in prescribing medicines, Mr. Bull?
Mr.
Thank you,
Chairman,
Mr. Chairman,
Senator Hutchins, I'm sorry, anything to do with prescribing.
thank you.
Let me ask one. If we clean up that, which seems to have been an incomplete house job in cleaning things up, this, as I read the bill as it comes to us, it is strictly relating to licensure boards. And obviously, if they deny a license, that affects the hospitals and whatnot. But otherwise, I don't see it having any impact on what the hospitals do.
Mr. Chairman, that's been our big concern with this all along. And so if we clean that up, again, I don't think it's necessary because we've already heard from the licensing board that they're not taking action. But I think if we clean that up, it'd be in a much better place. Thank you.
Okay. Thank you very much. Senator.
Thank you, Mr. Chairman, members of the committee. My name is Laura Pearson, Senate District 14. HB 164 is absolutely necessary. The people are asking for us to protect them. During COVID, there were thousands of people asking for medications that hospitals and doctors would not prescribe because these medications were not listed as medications that were approved. Because of federal funding, doctors and pharmacies were threatened if they did not comply. We must protect our citizens. Let doctors have the freedom to do what they think and know is right, and protect our citizens' rights to medications. I'm here. I ran for this office because of COVID, because I was one of those citizens that was looking for protection. Please pass this bill. Thank you, Mr. Chairman.
Questions? Thank you very much. Yes, sir, you're next.
Yes, sir. My name is Jason Caswell. I'm a board-certified family practice physician that owns Cowboy Concierge Medicine, where I provide primary care, direct primary care to the community. I have over 16 years of experience as a physician. I support this bill, and the way I see it is it protects prescribers from over-meddling administrators that aren't in the exam room nor have any knowledge of medicine, or succumb from intimidation, posturing, fear tactics of certain employers. Off-label does not mean unsafe nor ineffective. Anyone that would tell you different is completely wrong. Your primary care physicians are serving too many masters. They're serving the group practice administrator, the guidelines, they're serving insurance companies. Your physician should just be serving you. Obviously, this is about COVID, and I'm one of very few physicians that took care of acutely ill COVID patients in the outpatient setting, and one of the only ones that was doing home monoclonal antibody infusions if patients, desired that therapy. I'm very libertarian when it comes down to practice of medicine. When I take care of a patient, I explain the options, risks, benefits, and alternatives, and it's up to the patient to decide that. They're the only fact finder. I do appreciate, again, the protection of children with the abortifacients, as well as transing of the children. As I've always said, I think a trans child is much like a vegan cat. We all know who's driving that ship. There's a question about protection of patients, and There is multiple remedies for patients. This is not carte blanche at all. There is administrative law where the patient can launch a, complaint to the Board of Medicine. There is civil law where you can sue a physician civilly. And if you report to the Board of Medicine and it rises to that level, the investigatory arm of them is the Attorney General's office, which is criminal law. So there's tons of protection still. This is not, an ability to run ripshod, with the practice of medicine. And moreover, as far as protecting patients goes, these are medications requested by the patients. This is not a physician saying thou shalt must to a patient. These are the patients are requesting these medications. And it is up to us to make sure that they understand informed consent. But I've had plenty of patients that have not done what I personally would do in that current situation, but it's not up to me. It's up to me to explain the reasonable options, benefits, and alternatives, and then set their plan in motion. We also what happened during COVID when we had too much of a centralized focus with regards to medicine. There's a question about severability or, removing lines and stuff. Let's not let perfect be the enemy of the good, I plead. And there's a question too about FDA approved meaning safe. Well, valdecoxib or Bextra was approved, deemed safe by the FDA, and then it was pulled from the market. And, nobody's sneaking in medications. It's one of those things that if you were to do that as me, a community attending physician inside a hospital, you don't have credentials to practice within that hospital, and the Board of Medicine would take action against you as they should. And as far as remdesivir goes, remdesivir caused nephrotoxicity and killed patients' kidneys. I think that line 18 must stay because we're not just talking about the Board of Medicine, we're talking about hospital groups that can alter a physician's credentials, and that will be an indelible scarlet letter reported to the National Practitioner Data Bank. With the mifepristone, the chances of that being used for GI ulcers is slim to none, and Slim just left town. Just because it hasn't happened doesn't mean that it can't or won't. Our Board of Medicine is extremely reasonable and good, but boards of medicine can be much like a finicky cat. So, at that, I'm done, if you guys have any questions.
Okay, questions? Senator Hutchins?
Mr. Chairman, thank you. Is it Cos or Cas?
Caswell.
Caswell, thank you for your testimony.
Yes, sir.
You said line 18 needs to stay as is. Do you have the bill in front of you? So I know, it's the engrossed version is what we're looking at.
Okay, the first iteration? is that-
Engrossed.
Okay, will you read line 18 to me? I'm sorry, young lady.
I'll start with 17, it says related licensing board, comma, including disciplinary action, comma, and then line 18 says loss of employment, comma, hospital privileges or credentials. You like that statement?
Absolutely, because this is about hospital administrators, over meddling hospital administrators, taking negative action against a physician's, credentials, which, like I said, that gets reported to the National Practitioner Data Bank, and that can be an albatross around the neck and an indelible scarlet letter, ma'am. Does that
Thank you,
answer your
sir.
question?
You did.
Yes, ma'am.
Appreciate you.
Yes, ma'am.
Senator Steinmetz?
Thank you, Mr. Chairman. My question would just be, it looks like the House took out, it used to say related licensing board or employer. And so they took out or employer. I just wonder there's two ways to clean it up. We could add or employer back in, or it doesn't sound like we really want to take out line 18. So would you recommend adding or employer back in?
Chairman, Senator, I absolutely would. Thank you for correcting me on that, because again, this should be, I think employer needs to be in there because you have the Board of Medicine that gives you a license, right? And then you have, in order to practice in a hospital, that hospital has to give you privileges or credentials. So if you don't have a license, you won't get privileges or credentials. But, if a hospital were to come, down on you, wrongfully so, in my opinion, that is still, like I said, indelible scarlet letter and albatross around your neck. Does that answer your question, ma'am?
Yes, thank you so much.
Yes, ma'am.
Okay. Thank you. Yes, ma'am, you're next.
Good afternoon, committee. My name is Kathy Sigliano. I wasn't really prepared to speak on this bill, but I jotted down some things just while I was sitting listening to other testimony. I'm in support of this bill. I would just ask, why would anyone prevent a doctor from prescribing a medication that they know would help or even possibly save a life of a patient, as we saw with ivermectin? Why would we allow doctors to be threatened if they prescribed a certain medication? My husband actually came down with a very severe case of COVID, and the doctor that was just sitting here to my left actually prescribed a cocktail for him. And that cocktail was given to him too late because we did want to see a doctor here locally that was told in our community was prescribing ivermectin on the early onset of COVID, but he had been, I don't want to say fired, but possibly threatened in a way to leave the practice. He was not able, he didn't have an office during the time my husband contracted COVID. So we were unable to get him medication when he came down with that. And Dr. Caswell was able to give him that cocktail, but it was just a little bit too late. He ended up having to go to the emergency room here, and even though he had been given that cocktail, he just progressively got worse. He was on oxygen, and it took probably, I would say, about a month for him to actually come out of it and be a normal human being. I do completely believe that if he was able to be given ivermectin sooner, he would not have had the severe case that he ended up coming down with. So I am in support of this. And just a little, I guess, note that I would say, maybe some doctors didn't lose their licensing, but these boards have a lot of influence and they can put a heavy hand on how doctors are treated and what is allowed for them to be prescribing. Thank you.
Okay, questions? Thank you very much. Anybody else here? Anybody else? Quickly, we're going to go to the online people almost immediately.
Thank you, Mr. Chair, members of the committee. Tony Deckleber with the Wyoming Nurses Association. And we, like you've heard in the past, do not object to the part of that this is allowed, the part of the bill that allows prescribers to give medication since it is already allowed. I am a registered nurse. I've been an RN for 45 years. I am not a prescriber, but I have worked as a clinician, I have worked as an administrator, and now I own my own business here in Cheyenne. You are policymakers and you are making policy, and those are the rules that the members of the state and the citizens of the state are supposed to follow. When a person is employed, the first thing they're told is to read the policy procedure book. And this is the law of the facility that they work for. And those are the rules that they have to work for. This is what, and I would tell my employees, this is your Bible. This is what protects you. So when you follow the policy, and I've been called as a witness on a malpractice case, and one of the questions I was asked was, did you follow the policy of your facility? And so policy is important. And so taking out employer protected the employer somewhat. But when people choose to violate the law, there are consequences. If people choose to violate the policy of a facility, then there are consequences. And sometimes those are terminations, sometimes they're just reprimands, but we have to follow the rules that are set forward. And if we don't like the rules, then we don't have to work there. So I really feel like, part of the bill is okay, even though it's unnecessary. But as an employer, as someone who owns a business, I have an American Heart Association business, I have to follow their rules. And if I choose to violate the policy, I actually had a conversation today with one of my instructors, and I said, the policy of. You have to follow the policy, and if you don't want to follow the policy, that's fine, that's your choice, but you don't get to work for me. So, just because you can do something doesn't mean that you should. And so we oppose that part of the bill. So I would stand for any questions.
Senator Hutchins.
Mr. Chairman, Ms. Duckclever, thank you for your testimony. Just concerned where you say, you're talking about policy. So it seems to me that it's okay to prescribe off-label drugs in one case, but are there hospitals, clinics, whatever, that are saying you can't do this?
Mr. Chairman, Senator Hutchins, yes, because the medical team, and when I worked as an administrator, like Eric Boley testified, the group would get together and I had a medical director, the other nurses, the pharmacy, and we would get together and we would develop policy based on what was best practice, what was allowed, what was going to be the best for our patients, what was going to be okay for the staff. And I lived, and many of us have lived through the HIV epidemic when that came out, and there were certain things that we were allowed to do, and there are certain things we were not allowed to do. And sometimes the policies come from people or groups that we don't have any control over. I mean, CMS develops policy, and as nurses, when COVID came out, we were first as the angels, the heroes, and that morphed into that we were the enemy, and we still continue to be the enemy, not because we're not trying to give good care, but we're trying to follow policy. Because we can lose our jobs when we say, well, I can do it, but I don't want to, or I can do it, so I will, or I can't do it, so I will. And I just feel like, it leaves me as an employer, the hospital administrators as employers kind of in a bad place because they have no ability to discipline, they have no ability to terminate, because it's like, well, they can. I mean, I can do a lot of things. What's interesting, in my profession, I work with long-term care facilities. Nursing assistants are trained how to do CPR. And yet, the policy of our long-term care facilities is if they find someone unresponsive, they're not allowed to do it. Why? Don't know. But, if we don't like the policy, then get on the policy committee, and just like we're trying to influence and support and change legislation, I mean, it's the same thing. You can get on the committee and state your case and try to change the policy.
Thank you very much. Seeing no further testimony on present, we'll go online, and let's try to hold it to a minute or two. We are running out of time, and I don't want to filibuster the thing. So go ahead and admit the first person, and let's proceed.
I guess Melinda Carroll is ready to testify.
Okay, go ahead.
Good afternoon, Mr. Chairman and members of the committee. My name is Melinda Carroll, and I represent the Wyoming Pharmacy Association, which speaks for hundreds of pharmacists, technicians, and pharmacies across the state. And I appreciate the opportunity to testify today in opposition to House Bill 164. This bill, while well-intentioned, has unintended consequences. The frustration that led to its creation is understandable. Patients want access to treatments they believe will help them. However, this legislation does not solve the real challenges that limit access to certain medications. During the pandemic, demand for drugs like hydroxychloroquine and ivermectin skyrocketed overnight. The supply chain could not adjust quickly enough, leaving pharmacies unable to obtain these medications through no fault of their own. At the same time, insurance companies began auditing off-label prescriptions, often demanding full repayment from pharmacies. Many pharmacies had to make the difficult decision to stop dispensing these drugs off-label to avoid severe financial losses. Another issue was the rise of discount cards, which promised patients lower prices but come at a cost to pharmacies. These cards do not function like traditional insurance. No reimbursement comes from the company offering the discount. Instead, the entire cost is paid by the patient at the counter. To make matters worse, pharmacies must pay a fee just to process the transaction, and in many cases, the price dictated by the discount card is below what the pharmacy paid to acquire the medication. This means that pharmacies would lose money on every prescription filled under these terms, making it unsustainable to dispense certain medications. Beyond financial concerns, pharmacists have a legal and professional responsibility to ensure prescriptions are appropriate. However, enforcement agencies have not always deemed these efforts satisfactory. The opioid crisis demonstrates that despite pharmacists exercising their professional judgment, enforcement actions primarily targeting pharmacies and pharmacists, while many prescribers face fewer consequences. While state boards of pharmacy do not always take direct action, it was the Drug Enforcement Administration and state attorney generals that led major investigation and enforcement efforts. This bill could expose pharmacists to similar risks, potentially limiting their ability to apply professional discretion in dispensing off-label prescriptions while increasing their legal liability. The reality is that off-label prescribing is already legal and occurs every day. Pharmacists work with prescribers to ensure the safe and effective use of medications without adding unnecessary statutes. House Bill 164 does not increase patient access. It only adds risk to pharmacists and pharmacies. For these reasons, I urge you not to advance the bill. Thank you for your time, and I am happy to stand for questions.
Okay, let's proceed with the next. We're going to try to run this just fast as we can. And if necessary, we'll drop the people that are out of state. Okay, go ahead. Who's next?
Is it me? Good morning.
Yes.
Good morning.
Introduce
Chair.
yourself and proceed.
Good morning, Chair and committee members. My name is Laura Pavey. I am a Sweetwater County resident. I'm here today to express my strong support for HB 164, legislation that would enable our medical providers to prescribe and dispense FDA-approved medications for off-label uses when clinically proven for their patients. This legislation resonates deep with me and other countless Wyomingites who have experienced challenges accessing healthcare. Beyond medication access, it represents an opportunity to improve our care and quality and reduce costs across the state. My personal experience has shown me the difficulties patients face when seeking effective treatments, particularly when conventional options are proven inadequate. Consider, for example, somebody who's suffering from chronic pain and who has exhausted all FDA treatments without success. I myself could barely walk 3 years ago. My physicians could identify different types of medications that had proven success, but had hesitations to prescribe due to potential liability concerns. This would allow healthcare providers to access or exercise their own professional judgment without unnecessary concerns, and would allow citizens to not go through so many different physicians in order to find one who will believe in them and take a risk to go with an off-label prescription. The financial implications are particularly significant in rural Wyoming, where their healthcare access is often requires long-distance travels. Off-label prescribing frequently involves well-established, cost-effective medications. When patients can access affordable and effective treatments, they are more likely to maintain employment, avoid emergency care, and preserve family stability. This legislation also provides important protection for our healthcare providers. It shields them from penalties when acting in good faith while incorporating responsible safeguards. I believe that this bill further helps doctors' ability to do no harm. I urge you to vote yes on HB 164 and the other two bills today, and I stand for questions.
Okay, thank you. Bring the next one on. And can you all time these two? Okay, go ahead, sir. Introduce yourself and proceed.
Thank you, Mr. Chairman, committee. My name is Jonathan Lang. I'm a pastor in Evanston and Kemmer, and I'll be brief. But I want to bring up one aspect of this bill that relates specifically to spiritual care. namely the conscience. When a medical practitioner is convinced through his or her training and through years of experience that any treatment is best for the health of his patient, it puts a burden of conscience to do the right thing, and is further strengthened by the Hippocratic Oath. So I'm not the only pastor to have been put in a position of giving spiritual care to physicians who were given an impossible choice: either withhold the best care possible from a patient or risk severe personal consequences. So to the extent that such an impingement on conscience is driven by the state, and I realize that this is a complicated matter, but to the extent that it is driven by the state, it's wrong. And the state law should make clear that citizens are free to offer the best possible care to their neighbors. Recently, the federal HHS administration recognized this reality and put a temporary halt to communications from the CDC, recognizing that government communication, eo ipso, by itself, influences the practice of medicine. Now, I understand that the State Board of Health never acted on the threat to investigate, but the very fact that the threat existed influenced employer policy, and this bill takes that thumb off the scale. If this legislation could prevent such a blanket pronouncement from the State Board of Health, it could remove significant state impingement on the conscience. So thank you for your time, Mr. Chairman. I stand for questions.
Okay, thank you. Bring the next one on. Okay, sir, go ahead.
Hello, I'm David Kirkham. I'm from Provo, Utah, out of the state. We're your next door neighbor. Good morning, or good afternoon, Mr. Chairman. Thank you and the committee for letting me testify on Representative Brown's bill in favor. As I've sitting here listening to everybody speaking, I've noticed that it's the corporate interests that are against this, and it seems to be the patients who are for this. And I was diagnosed with prostate cancer, and I'm only 58, and my father had it, suffered horribly from it, suffered for 30 years from it. My grandfather died from it. Both of my mentors died from it. It's a horrible disease. And if you go and talk with any oncologist, I don't care which oncologist you go talk with, they will not speak with you about anything that is out of standard of care. My brother-in-law is a radiation oncologist. They won't speak about anything that the overlords tell them that they can't do. And that's why I think that laws like this are very important. And actually, I want to help bring this law to Utah. That's why I'm testifying here in Wyoming. That's how important I think this is. And, I remember I asked my brother-in-law about ivermectin. He's MD, PhD, and he simply replied very quietly to me, ivermectin has well-known anti-cancer properties. He spends his life researching cancer. I've been on very high dose ivermectin for 4 months with literally absolutely minimal side effects. And if people want to be able to get a hold of these medications, they should. Just 2 months in, my PSA was cut in half, prostate specific antigen. It's a marker, not a great marker, but it is a marker. We don't have great markers in prostate cancer, unfortunately. It's the only one I got, but it dropped by more than half. And so my brother-in-law, when I told him, his reply was, that's incredible. So I don't want to take much of your time. I'm from Utah. I'm happy to answer any questions, Mr. Chairman. But please, I want to bring this bill to Utah. I think it's great. I'd love to see my neighbors in Wyoming pass it as well.
Okay, thank you. Is that all of them, or how many more have we got? I believe 2 more. 2 more. Let's get them on quick.
Am I on?
Yep, go ahead.
My name is Ronnie LeBlanc of Sheridan, and Mr. Chairman, I've resided in Wyoming for 25 years. I hold both a doctorate and bachelor degrees in pharmacy. I'm a former member of the Wyoming Board of Pharmacy, and I've practiced in the state since the year 2000. I speak in support of HB 164, Mr. Chairman. Long-standing off-label prescribing permissions have already been discussed. This bill would provide protection for practitioners who utilize FDA-approved drugs outside of the realm of their common use in order to give Wyoming folks treatment options. During my employment with a large corporate pharmacy company, Mr. Chairman, I was given legal prescriptions for ivermectin, but was instructed by corporate, not to fill, but to send the Wyoming resident elsewhere. This drug is a Nobel Prize winning drug. It's approved for treatments. It's also been known to inhibit the protein transport in COVID infections, and more importantly, it can induce cancer cell death, yet displays a very safe side effect profile. It may show promise as a drug, Mr. Chairman, but it will never be indicated for the treatment of cancer, as there is no enormous monetary reward. Wyoming prescribers should have the freedom to use this drug without fear of repercussions from government-influenced entities. Here are the facts. There are fewer doctors making independent treatment decisions because more prescribers are being consolidated into large clinics and employed by hospitals. As previously mentioned, hospitals' P&T committees will allow only their approved treatment protocols. That clinic's administrative department determines the treatment algorithms that those prescribers and doctors are going to follow. Wyoming residents are having possibly effective medications withheld due to department rules. For example, many doctors are hospital employees and so are prohibited from using medicines.
Sir, you're out of time. And
Thank you, Mr.
sorry,
Chairman.
we've got to get this done. Who's next?
Mr. Chairman, the rest have declined to.
Rest have declined. Okay.
May I be allowed to
Committee.
finish, Mr. Chairman?
Committee, we're up against it on the time on this one. There is the taking out that line 19 going to be controversial?
Mr. Chairman, yeah.
Okay, then we're going to deal with it strictly in a full committee. So we'll, at that point, go then to House Bill 135. I saw the representative who sponsored this somewhere here. Did he step out? Then we'll go to House Bill 96. And that representative is here, so. House Bill 96, prohibiting mass vaccine and testing discrimination. Proceed.
Thank you, Mr. Chairman, committee. My name is Darren McCann. I'm a House Representative for House District 48, here to present House Bill 96. I'd like to start off with some talking points, if that's okay, and then go to the bill itself, okay? 12 states have already passed similar laws. There's been some pushback as far as the feds still having regulations, especially in the hospitals and the airports, which is mainly what I've been hearing about. But to this point, there's never been any enforcement of those laws. I certainly understand that, particularly with the hospitals and the feds weaponizing reimbursement, but thus far, they have been reimbursed and continue to get their funding. On that note, the Senate and House leadership will be going to Washington, D.C. shortly after session, and I will be in the speaker's ear to get in the health department's ear to get rid of these regulations. Onto some bullet statements, just some talking points. Protection of individual rights. This bill ensures that individuals are not discriminated against based on their personal healthcare choices, such as vaccination status or mask wearing preferences. Number two, promotion of personal freedom. It upholds the principle of personal freedom by allowing individuals to make their own health decisions without fear of losing access to public services. Legal recourse. It provides a clear legal pathway for individuals who feel that they have been discriminated against, allowing them to seek justice and compensation. Consistency of public policy. The bill creates a consistent approach to public health policy, ensuring that no one is unfairly targeted or excluded based on their health care decisions. Supported by our support for vulnerable populations. It protects vulnerable populations who may have valid reasons for not wearing masks, getting vaccinated, or undergoing medical testing, encouragement of informed decisions. By removing coercive measures, the bill encourages individuals to make informed health decisions based on their own research in consultation with healthcare providers. Respect for privacy. The bill upholds the privacy of individuals by not requiring them to disclose their health status to access public services or goods. Actually, that's a HIPAA violation. Reduction of government overreach. This bill limits government overreach into personal health decisions aligning with principles of limited government. Support for civil liberties. It reinforces civil liberties by protecting individuals from being forced into health care measures that they do not consent to. And of note, we've all seen the beach scene in California where the guy was by himself and was arrested. But that did happen in Wyoming as well. There was a student at Lander High School who was arrested for not wearing a mask. This is a good example of how easy government entities can enter into tyranny. And if you want, I'll be happy to go over the bill, but if you want to shortcut that in name of time, I'm all right with that too.
Give us a 60-second summary.
Okay. All right, it does create a new statute, 35-4-140. And the first part of this goes into definitions of COVID-19, COVID-19 medical testing and face covering, as well as vaccination. The second part, which is the meat of the bill, no person who receives subsidies from the state or federal government shall, and you got those two descriptions, basically to refuse, withhold from, or deny a person any services, goods, facilities, advantages, or privilege that are public in nature. And then the second one, is as far as publishing, no, you must wear a mask sign. That was one that was hit by the airports. And again, none of these have been enforced by the feds at this point. The last part, which is the teeth of the bill, any person aggrieved by a violation of subsection B of this section may file a civil action to recover a civil award of not more than $5,000 and an effective date of immediate if passed. I stand for questions.
Okay, questions? Senator Hutchins.
Thank you, Mr. Chairman. Just quickly, Representative McCann, basically, we're saying that if you are not vaccinated or don't wear a mask, you can't be punished. Basically.
Correct. Okay. And this is strictly in entities that receive public monies.
Go ahead.
Okay. Okay, go ahead.
Thank you, Mr. Chairman. Representative, so I'm looking at page 3, line 6, no person who receives subsidies. I was wondering if you had considered, since you're dealing with public monies, an appropriation or subsidies, because we here at the legislature appropriate money to our, it's not necessarily a subsidy, it's a direct appropriation to all of the agencies of the state.
Mr. Chairman, I'm not aware of any of that coming up, but I'm certainly friendly to that type of wording.
Okay, thank you.
Good catch.
Yeah.
Senator Hutchins.
Thank you, Mr. Chairman. What about in hospitals? In the hospital, you're a nurse, a doctor being asked to wear a mask, is that included in this bill as well?
It is.
Okay.
I'll certainly go into it further, but in the case of time, it's up to you.
Thank you.
Okay. Anything further? I'll ask one question, page 3, line 7. State or federal government, can we isn't that outside our ability to reach things the federal government? Because somebody's getting a federal grant, that we can penalize them? I have a little trouble with that.
Honestly, Mr. Chairman, that didn't really come up in our conversations that I recall. I'd have to get with LSO on that one
Okay,
just to see.
think about that one.
Yes, sir.
Okay. Further? Okay. How many people are going to want to testify in this bill? 1, 2, 3, 4, 5, 6, 7. How many people are going to want to testify on the 135 bill? 1, 2, 3, 4. Okay, what we're going to do is hear, since the representative sponsor has come back, we're going to hear about 135. We're going to hear testimony on that first, and then we're going to get to the other bill further if we can get the time. So, briefly. Sorry the first bill took so long. We had so many witnesses.
That's fine. Thank you, Mr. Chairman. Joel Guggenmoss, representing House District 55. And my co-introducer is Sarah Penn.
Hello, I'm Sarah Penn.
I bring to you House Bill 135. And this bill is about medical freedom and represents an important step forward in empowering patients and enhancing public health in Wyoming. By authorizing and regulating autologous and direct blood donations, it allows individuals to take proactive steps in ensuring their own or their loved ones' safety during medical procedures. This legislation prioritizes patient autonomy while maintaining high safety standards for blood donations. It also ensures that healthcare providers and blood banks operate with clear guidelines, fostering a reliable system for storing and utilizing donated blood. Additionally, by allowing reasonable fees for facilitation and storage, the bill ensures the sustainability of these services. With the Department of Health tasked to establish necessary rules, this initiative provides a balanced, thoughtful approach to improving patient care across the state. With that, I'll walk you through the bill briefly. Page 1 gives a synopsis of the bill. Section 1 creates a new statute for autologous and direct blood donations. And then page 2 goes into definitions, and just for everybody's information, autologous blood donation means when a person donates their own blood for personal use during a future medical procedure, and direct blood donation means when a person donates their blood specifically for the use of another person during the other person's future medical procedure. Subsection B, C, and D go into the requirements for the hospitals or other healthcare facilities and the blood banks. And page 3, section 2 says the Department of Health will make the rules necessary for implementation, and then page 4 gives the effective date. With that, I'll take any questions.
Committee? Senator Hutchins.
Thank you, Mr. Chairman. Representative Guggenmoss.
Got it.
On page 3, section D, where it talks about the blood banks charging a regular fee, a question was brought to me about this fee being the regular charge. Can the blood banks charge a special fee because it's your own blood?
Representative, go ahead.
Mr. Chairman, did you want to? Go ahead. Yeah, go ahead.
All right, thank you, Mr. Chairman. So I've been learning a lot of information, even just as fast as last night, as far as how a lot of this works. So it depends on where you go to donate your blood. In Wyoming, we have Vitalant. We do not use Red Cross. We have Vitalant. In other states, there are many opportunities to donate blood. There are quite a range of fees. Some blood banks do not charge an extra fee for autologous or direct blood donations. The Red Cross, I'm hearing, charges about $100 per unit for that. Vitalant is about $500 to $800 per unit. The turnaround time can be as short as 3 days. It can be as long as weeks. Red Cross is generally about 2 or 3 weeks turnaround time, and I'm hearing that Vitalant may be longer than that. And so there are extra fees charged, especially with the bank that we use.
Thank you.
Okay, question from, let me follow up on that one, and I'm really looking at the language on page 3, starting at line 6. It would seem to me that, and I know there are circumstances where it's very useful to have using your own blood. It prevents rejection problems, where that's a special risk, and sometimes having blood from a relative can help in that scale. But it seems to me that inherently is going to cost more, because you're going to have to segregate it, specially label it, and keep it for just one purpose. And it's going to be administratively more complicated, I think, and limited. So I would think you would almost have to charge more. So do we really want the provision on page 3, starting at line 6, or is that something that's going to cause trouble?
Thank you, Mr. Chair. On page 9, it does go into that the blood bank may charge a fee.
Page, which?
Or line
Or-
9, line.
Yeah, line 9. Does go into the blood bank may charge a fee to store the donated blood, so we're kind of trying to take that into account so that they can, for the storage fee, make some money on the process. Yes.
Okay. Misunderstanding.
Thank you, Mr. Chairman. Have you seen the proposed amendment from Vitalant? Vitalant?
Mr. Chairman, no, I have not.
Okay, it looks like they'll get you one. I'd sure like you guys to look at it before we consider it.
Okay. Well, they're looking at it. We'll call you back on that one. Who wants to testify on this bill? Okay, come forward, fill the chairs, and let's proceed as rapidly as we can. And do try to be brief. If somebody gets long-winded, I will cut you off. I'm conscious of trying to avoid filibustering the bill. Okay, you, and you, in that order.
Okay, good afternoon. My name is Randy Ray. I'm the Transfusion Services Supervisor at Cheyenne Regional Medical Center, and today I'm representing myself, other health makers in the state, and the Wyoming public. Firstly, to my knowledge, this bill would not apply to any hospital in the state. Being that Wyoming is 100% reliant on out-of-state blood suppliers, no Wyoming hospital collects and processes its own blood products. Hospitals may host blood drives on their premises, but they are performed by employees of the blood center and shipped out of state for processing and distribution. All that is listed in the definition of the hospital. It says only hospitals that do those things apply. Secondly, the denial criteria only mentions physical reasons that a donor is unfit to give. There's no provision to allow denial based on blood type incompatibility or infectious disease status. If you don't know, the quickest way to kill a patient with blood products is blood type incompatibility. Your blood will literally clot within your veins. Since there is no denial based on that, it seems like this kind of overrides the FDA and all the applicable accrediting agencies such as Joint Commission, ABB, CAP, and a bunch of others. You can't give incompatible blood, and I feel like that needs to be outlined as a reason for denial. Just because you want your spouse's blood, if it's incompatible with you, that's not a good idea. Lastly, if this bill is concerned for fair billing, hospitals must follow the CMS billing guidelines on this regarding transfusion in order to qualify for CMS reimbursements. And like you were saying, it is an additional fee for the extra processing and storage. But I don't know of any hospitals in the state or out of state that don't follow those guidelines because we want to reimburse. In summation, as it's written, I don't think this bill can stand. I understand the intent, but for the safety of the Wyoming public and to sustain a blood supply in the state, I would urge you to vote nay, mainly because if we go against these federal guidelines, we're at risk of losing FDA registration and the ability to transfuse as a whole within the state. That's all I have.
Okay. Senator Hutchins.
Thank you, Mr. Chair. Ma'am, Randy, I'm sorry, I did get your name. It would stand to reason that you would have blood that was compatible with your blood. I wouldn't come to you and say, hey, you're my best friend, let's go get your blood and use it for my next procedure. So it would stand to reason if a doctor prescribed this for you that you would get blood that matched your own blood type, wouldn't it?
It would have to go through, in this case, by talent, they wouldn't know until they did the testing on the blood. But I feel like having this regulation without that provision kind of makes us feel like we're being forced. I don't know of anyone in the blood bank community that would want to transfuse incompatible ABO blood. But I would really like to see that as a reason for denial, apart from just physical well-being of the donor. Thank you.
Okay. Thank you very much. You're next, and be brief.
I got you. Thank you, Mr. Chairman, members of the committee. My name is Patricia McCoy, and I'm here today to speak in support of House Bill 135. This bill offers practical healthcare solutions while respecting personal values and medical choices. Let's start with some numbers. In 2023, over 45,000 transfusion reactions were reported nationwide, from fevers to rare but serious cases like lung injury and bacterial contamination. While our blood supply is safer now than ever, these risks still persist. About 1 in 1,000 transfusions still see a reaction. For some, like those planning surgery, self-donated blood cut that risk to zero. No mismatches, no infections, direct donations from a trusted family member or friend offer similar peace of mind, especially when blood shortages like the Red Cross's recent crisis leave hospitals scrambling. Beyond safety, this bill supports personal freedom. Many of us want control over our health care, whether it's to avoid a stranger's blood or ensuring a loved one's donation goes to us. The bill maintains appropriate safeguards while respecting individual healthcare decisions, things Wyoming values. And yes, faith matters too. Some in our state hold religious convictions against pooled blood. This bill doesn't force anyone, it simply opens doors, letting them align medical needs with beliefs. It's not just about religion, though. It's about options for all of us, from ranchers planning surgeries to parents ensuring their child's care. Importantly, this bill doesn't mandate changes to current practices. It simply expands options. Whether someone is planning for surgery, concerned about blood shortages, or has personal or religious convictions about blood transfusions, House Bill 135 provides a framework for safe, supervised alternatives. I respectfully urge you to pass House Bill 135.
Okay, thank you. Seeing no questions, Mr. Boley.
Mr. Chairman, committee members, Eric Boley with the Wyoming Hospital Association, and we don't have a position on this. I queried my membership. There are none of our hospitals that currently preclude direct contributions. However, it all hinges on Vitalant, and all of our blood goes through them. You've heard that there will be additional expense. There are some concerns, you may hear this when you hear from Vitalant, that a lot of these units of blood go to waste after a period of time. Some of our members have considered being able to collect that, and we've heard that one piece of the equipment alone is like $60,000. And so I don't think we'll see any of our hospitals actually start gathering or taking these donations directly. And so we would have to defer to Vitalant, but I do believe that there should be additional expense incurred just because of the processes that take place. With that, I'd answer any questions.
Senator Hutchins.
Thank you, Mr. Chairman. Mr. Boley, the expense, would that be on the patient or Vitalant?
Mr. Chairman, Senator Hutchins, yes. It's gonna cost extra money to process the blood, and then that cost should be passed on to the patient.
Okay. Okay, Mr. Pickard.
Good afternoon, Mr. Chairman, members of the committee. My name is Dave Pickard. I'm representing Vitalant here. I will say that we have our medical doctor online, that he would like to provide some testimony. But in the interest of time for right now, while I have the mic, what I'd like to ask is that you do consider the amendment that I have proposed. There's two components of that amendment. The first one at page 2, line 23, after the word unless, it would insert, it is not medically advisable and would risk patient harm, or, and the line then goes on. The good doctor online will be able to explain the purpose of that. And then what has certainly become aware to the committee and to the audience right now is the additional cost that comes with following this blood supply all the way through the process. Even though the bill in the title says authorizing reasonable fees for blood donations, it then turns around on page 3 at line 6 and says a blood bank may not charge more than their regular fee. It doesn't talk about reasonable or commensurate. The amendment in front of you inserts the word commensurate and removes not more than regular. I understand in just a brief conversation with the bill sponsor that might not be their word that they would like, so we would need to come up with some type of commensurate word that would, again, talk about what would be reasonable to be charged in this circumstance. With that, I'll stand for any questions, but again, the medical doctor for Vitalant is online.
Can we identify who that individual is and put him on right now?
While he's doing that.
His name is Dr. Vassallo.
Yes, Dr. Vassallo is.
Yes, and then, Lynn, if there's time, we'll have questions for both of them.
I assume you can hear me?
Yeah, we can hear you. Thank you, Mr. Chairman. Quick question. On page 223, where you want to amend it, why in the world would any doctor prescribe using your own blood unless it was, if it was harmful? Why would he advise someone to do that if it was harmful? That was my question.
Let's take that under advisement and let's hear you, doctor.
Absolutely, and I'll be happy to address that question. Thank you, Mr. Chairman and committee members. My name is Dr. Ralph Vassallo. I'm Chief Medical and Scientific Officer with Vitalant, your primary blood collector and supplier in Wyoming, along with the American Red Cross, and we proudly serve 28 hospitals in this country. Here today to oppose House Bill 125 because it's unnecessary, is unduly burdensome, and would negatively impact donor and patient care. Donor and patient safety is our top priority. We work 24/7 to support the Wyoming and overall U.S. blood supply, which is the safest in the world. And a part of that exceptional safety profile are our practices through which we already effectively facilitate medically necessary autologous and directed blood donations. Currently, when a doctor initiates an autologous or directed donation for a patient, blood center physicians who are specially trained in transfusion medicine are consulted to ensure it's medically necessary and won't pose unrecognized harm to patients. And House Bill 135 seeks to remove blood center physician involvement, which will most certainly lead to adverse patient outcomes. Please also consider the community blood supply meets the vast majority of patients' blood needs. Today, less than 0.04% of blood transfusions are autologous or directed, and there's simply no need for the bill. Second, if autologous and directed donations were to unnecessarily increase in volume, it would divert our limited resources. We are a nonprofit charity from maintaining the community blood supply for all patients. The bill also suggests that we may not be able to fully recover the costs of collecting and processing these donations, further impacting our ability to serve your community. Third, and most importantly, as a physician, directed donations are inherently less safe than the community blood supply. Those donations that are not medically evaluated and necessary pose needless health risks to patients, including unusual transfusion reactions, complications with future pregnancies, and may impact transplant eligibility for the patient. Further, directed donors, particularly family and friends, may feel pressure to donate and be less transparent about their health history, which can result in potential health risks for the donor and increase infectious disease risks for the recipient. So in conclusion, I urge you to oppose House Bill 135 as it is a solution looking for a problem that does not exist, provides no public health benefit, and could impact the reliability of the community blood supply as well as harming patients. I'm happy to answer questions, and we'll take those. Thank you.
Do your remarks apply to the situation where somebody's using their own blood for donating ahead and storing it?
Yes, about 2/3 of autologous units are thrown away. They're not used. And they also needlessly make the patient anemic before a procedure that will increase their risk of having a transfusion. And of course, all transfusions are subject to misadministration. You get the wrong blood. There are other transfusion reactions that occur as a result of storage during the storage lesions that occur during the storage process. So they're not entirely safe.
Minnie? Okay. Thank you very much, Dr. Pickard. Was there anybody else here that wanted to testify in this bill? Okay, we're essentially out of time. We're going to go in upstairs in 1 minute. So we'll carry all these bills forward. We'll discuss with Chairman Barlow as to how to proceed. This one strikes me as you may be onto something, but there's some complications here. It may be something we'll have to look into in the interim, but talk to Chairman Barlow about that. And on the third bill, I hope there'll be time, but we are short on time on getting testimony on finishing up in your bill. Okay,